Hi, so I'm Jacob Furr,
Hi, I'm Joseph Ephraim.
and we chose Close the Health Gap as our grand challenge. So, identification of the grand challenge. So, Close the Health Gap was identified in September 2016, and it focuses on issues of inequality within the healthcare system of the United States. So, while this issue is not unique to the United States, we have the capital and infrastructure to make meaningful change where other countries might not. So, the United States healthcare system disproportionately underserves marginalized groups based on determinants like race, sex, gender, economic status, and community of habitation. So this grand challenge strives to bring awareness to the issue and view it from a more holistic standpoint that accounts for the various factors that affect individuals' access to and when they have access to quality of care. So for some historical context, the first European settlers brought with them to North America a system that assigned value to individuals based on race, economic class, and gender. So in the 18th and 19th centuries, we can see the beginnings of a dual healthcare system based on class and race. So for class, this was white upper middle class people had access to home health care, doctors that were good at what they did, whereas lower class citizens, people of lower economic status, had to go to community health centers. There was long wait times. The care was not nearly as good. And then we also see the slave sub healthcare system in this as well, which was a separate healthcare system devoted to just slaves in America. Um, so medicine continued to advance throughout the 20th century, with some of these advancements coming from unethical experimentation on marginalized groups like Black Americans, the mentally ill, and the elderly. So think of Nazi Germany and the experimentation they were doing on people in the internment camps there, whether it was testing of medications or testing human body limits to other things. And then the Tuskegee syphilis experiment, which was on Black American males without informed consent that went on for years and years, which is um, testing the effects of syphilis without giving these people proper treatment. In 1964, it was a big landmark. Hospital segregation was outlawed, and then in 1965, Medicare and Medicaid were created. So this marked greater government control and involvement in healthcare and an acknowledgement of and conscious effort to correct systemic inequalities. So this was a big step, but we still have a lot of work to do.
All right. And then just to make sure we know about the populations that we're talking about and who is reducing these health disparities. So the populations that are most impacted by this health gap is racial and ethnic minorities, low-income households, rural communities, and immigrant populations. And then we also have our key organizations who are helping to reduce these disparities. We also have the federal agencies like the CDC and NIMHD. Um, they both help to bring health initiatives and research to make sure that these inequalities and inequities are identified as well as known. Then we also have the international organizations like the World Health Organization that helps to frame health equity as a human rights issue. And then we also have the civil society like the NAACP, who is advocating for people of color to bring back better reforms and better health policy and make sure that there is more outreach for these people. And then we also have our ethical responsibilities. These ethical responsibilities are based off of the foundations found in the code of ethics that we use as social workers. So to start off, we have the social justice, which is confronting inequality and then advocating for better access for health to make it more fair for each individual, dignity and worth of a person. Everyone deserves an equitable, sorry, equitable health opportunity. Um, and then also the importance of human relationships. This is to build trust and cultural competence. And then service. This is to prioritize the needs of vulnerable populations and communities.
So, exploring some human rights violations. So, the one we chose to focus on comes from the UN's International Covenant on Economic, Social, and Cultural Rights. So, General Comment 14 is what we chose to dial in on, and it expands on Article 12 of the Covenant, which is the right for health. And it outlines acceptable standards for meeting human rights, listing guidelines like availability, accessibility, acceptability, and quality. So, studies have shown consistently over the past couple decades that individuals of all races except white are less likely to receive coronary revascularization procedures, appropriate diagnostic testing for treatments and treatment for cancer, and proper treatment for HIV and AIDS. Um, and then in general, the U.S. lacks a universal healthcare system, which adds to a lot of these disparities, whereas other developed countries have a universal healthcare system. So, what effect does this have on communities? So, individuals of lower socioeconomic class and educational backgrounds are twice as likely to have inadequate health insurance coverage for medical procedures they need. It causes issues with access to culturally informed care and services like translators in poorer, predominantly non white areas. Pharmacies in majority white neighborhoods are far more likely to have proper supplies of opioids than those in majority non white neighborhoods. So the perpetuation of these issues harms not only individuals, but the communities in which these individuals live and work, and by in that, society at large.
Um, all right. So let's talk about the structural iniquities. So who is benefiting from the status quo that is going on with these health disparities? So we have the for-profit insurance companies. They profit from high premiums and limited coverage. Then we have our pharmaceutical and medical device firms that benefit from when we are having chronic illnesses become more common and stay more common. And then we also have large hospital systems like the HCA and Tenet that gain from costly procedures. Then we also have the safety net hospitals, which struggle from underfunding and inequitable um, care, healthcare. And then a key point that I wanted to bring in here was that the structural incentive is to make inequities financially advantageous, even for communities that suffer. So what are these needs that we need? So we need a firm framework for this, right? So we have our Bronfenbrenner's ecological system theory. Health disparities are shaped by multiple layers. We have our family, community, institutions, and policy. So how do we notice these needs? So we use Maslow's hierarchy of needs. Without access to basic healthcare, individuals cannot achieve safety, stability, or growth. And what are the future efforts that we're trying to strengthen? Building long-term community partnerships for sustained support, promoting cultural responsive care, and training in cultural humility for providers, as well as expanding school-based health programs to reach children early, but also developing community empowerment programs to help residents recognize and advocate for these local health resources.
Yeah, I think it's really important to look at Maslow's hierarchy when we're thinking of this, because that need for health, you can see it falls right into that second tier there, safety needs, right? So people that can't maintain health security are going to struggle to achieve needs that are higher on the pyramid, like love and belonging, esteem, self-actualization. And this perpetuates a cycle of poor upward mobility for people in low income and marginalized communities. So I think that's really important to know. And then looking at the ecological systems perspective, this helps us to place this issue across a lifetime, right? So in the microsystem, we see direct relationships such as family, pediatricians, school nurses, and dentists that are playing a key role in this. Moving out toward that mesosystem, the relationship between primary care providers and parents or schools and healthcare providers can influence the quality of care a child receives. So if a parent is working at a job where they have trouble getting time off and they can't be as involved in primary healthcare, we see that. We see that disparity there. Moving out to the exosystem, Medicaid's like or factors such as Medicaid eligibility, availability of clinics, and healthcare infrastructure can either bridge that gap of healthcare or it can widen it. Moving to the macro system, systemic issues that we've discussed, like racism, economic inequality, also contribute to disparities in healthcare quality of access. And then finally, the chrono system explores major events. So, global pandemic like COVID-19 that exacerbated these issues and brought them to light even more. Economic trends, policy shifts, and those disproportionately affect marginalized populations, furthering the gap in the healthcare system.
All right, now we're just going to lay down the framework. So the policy framework. So we have one big major policy reform is the Affordable Care Act. They denied or banned denials for pre-existing conditions, created insurance marketplaces, and as well as expanded Medicaid. But so the result of this was improved coverage and reduced racial disparities. The challenge behind it was still political rollbacks and non-expanding states, which deepen the inequities even further. Um, Also, we also have Supreme Court influences. We also have the NFIB Sebelius versus Sebelius in 2012. It upheld the ACA, but Medicaid expansion, which made Medicaid expansion optional. We also have King versus Burwell in 2015, preserve federal subsidies protecting affordability. And then we're going to go into our legal framework, the historical context. So it shows in our studies that employer-based coverage excluded many minorities. Medicaid and Medicare in 1965 reduced gaps, but didn't close them. We also have civil rights movement, which led to further hospital desegregation. Um, and then we also have the Tuskegee syphilis study, which even deepened racial injustices in medical research, and then kind of eroded the trust in healthcare among Black Americans. And then continuing disparities, as we said before, that these populations face worse access and outcomes when it came to health, as well as maternal mortality remains the highest among women of color. So basically, to wrap it up, achieving health equity demands for more broad policy reforms and community-specific solutions. This is just make sure that each community is making sure that each problem is being solved. And then we also have our micro and mezzo ways to close the health gap. Social workers, nurses, and communities need to all engage their clients together and work together. This is through case management, patient advocacy, and health and education and system navigation. We also have help the families apply for Medicaid and locate free clinics and understand their medical benefits. Shifting over time from service connection will lead to empowerment and cultural competency. Then we also have mezzo level for group and communities, integrated collaborative work care models as to combine mental health, primary care, and social work all together. More community initiatives to mobilize mobile health, as well as faith-based partnerships. The churches and neighborhood centers can help create a bigger space for screenings and education, as well as telehealth online post-COVID would help to reduce these barriers as well. While these strategies are easy to write down, it's hard to execute. And yeah.
Yeah, there's our references. Thank you guys.